without further ado, I mean, a few people are still coming through, and I will continue to host them, continue to admit them. What we're going to do today, in a moment, I'm going to introduce Syra, who is our speaker, and she will be talking for between 25 and 30 minutes, okay? If you have any questions that come up, you've got two options: either jot them down or remember them, or write them in the chat box. Once Syra finishes her presentation, then I will take some of those questions and ask her that. You know, there is this very simple rule that I'm sure many of you have heard: there's no such thing as a silly question, okay? So if there's anything that's not clear, if Syra's not made herself clear about anything, or if there's anything that you want some clarification on, please do ask. These sessions are a lot easier when they're interactive. So as I've asked, and I will reiterate, and I know I can see a couple of web cameras on, and that's great, but if the rest of you wouldn't mind switching on your web cameras, so Syra has a face to it when she's talking, that would be fantastic. Can't enforce that, not going to enforce that, it's just a polite request, and it would just make the sessions be a little bit more interactive. So Syra is a junior doctor. She graduated in 2018 from the University of Leicester, and she's now working towards a surgical career in trauma and orthopedics. She's currently taking an F3 year and working at the Major Trauma Centre at the QE in Birmingham. She's been part of the Medsuccess team since her second year of university, and is passionate and about teaching and medical education. I should have added, I've not introduced myself, so I should also do that as well before I do hand over. So my name is Fasih Khan. I am the founder of Medsuccess back in 2010. 10 years ago. It's incredible how time flies. By background, I'm a respiratory physician in Leicester, but currently undertaking research both in COVID and other respiratory conditions. And I will be hosting the evening today, and then filtering through the questions later. So Syra or Dr. Nassem, however you'd like to be referred to, welcome. Thank you for taking on the session, and I'm going to hand over to you now.
Thank you. So I'll just share my screen. So hi guys, I'm Syra. It's nice to be speaking to you guys all today. So I'll be talking about life as a doctor and some of the opportunities to explore. So I'll talk a little bit about what a day in the life of a doctor is typically like, a bit more about what it's like to be on call, the structure of training at the moment in medicine, some of the additional opportunities that there are in terms of research and academic training as well. So as Fuzzy has introduced, I graduated from Leicester in 2018. I did my foundation years in Leicester and Kettering, and now I'm working at the QE here in Birmingham in the major trauma service here. So a typical day in the life of a doctor. At the moment for me, I start at 8 o'clock. We start off with a handover. So the team from the night are present. They let us know about any patients that have come in overnight or any issues. And then they go home and we let them sleep. Then we do a board round. So this is where we talk through a list of all our current inpatients. We talk about what's going on, what the plans are, and we sort of plan out our day and what we need to do so we can prioritize things. Then we do our ward rounds. So ward rounds can sometimes be quite long and tedious, but they are the basic sort of foundation of medicine and being a doctor. I've included a mock entry of what a ward round is like, and essentially we look at a patient, we look at what they've come into hospital for, what their ongoing issues are, how we're treating these things, how we're managing them. We'll have a review of their basic observations, things like their blood pressure, any bloods and any scans that they've had done, and then we assess them, how they're doing. So I've put some examination findings further down where we've listened to their chest and we've listened to their heart as well, and then we make a plan for what we're going to do and the steps that it's going to take to get this patient better and get them home. So you'll do that for most of the morning, and then afterwards you'll try and maybe grab a coffee or grab lunch depending on what time it is, and then get to work on the jobs that you've accumulated from the ward round. So things like maybe discharge letters for patients that are going home, speaking to different specialties about jobs that need doing, maybe having conversations with family members and doing bloods and ordering scans and things like that. So then an on-call shift is a bit busier and a bit more exciting, in my opinion. There's two sorts of types of on-call shifts that you have. There are some where you cover the admissions unit. So this is where the patients who have come into A&E are coming in. So you're often the first or maybe the second doctor that's seen them, and they need a thorough review to see what's going on and to make plans. Or sometimes you're doing ward cover shifts. So this is where you're covering a large number of patients in the hospital, and you're essentially there to deal with any emergencies or anything acute that can't wait till the weekend is over or until the next day. So these shifts are your out of hours shifts, so typically from 5 to 10 on a weekday and overnight, and then on the weekends as well. As I said, you're looking after a lot more patients, and there's often less supervision than you have during the normal working day. Most places in the NHS still work on bleeps, so you often carry a bleep around with you, and the nursing staff can contact you for any urgent jobs. It's a very strange system at times, but it's how most places work. So this here, I've got a picture of my bleep and the handheld phone that I get to call people on. So what I've done, just to sort of give you an idea of what it's like to be on call, I've included a list of a few jobs that you might get on a typical on-call shift. Just for you guys to have a think about how you would prioritise these. So these are jobs that a nurse on the ward has called you to come and do. So there's 5 jobs here. The first is to come and review someone that's feeling a bit unwell. They've asked you to prescribe some paracetamol for a patient. Another one has asked you to come and finish a discharge letter for a patient that's going home tomorrow. A relative's patient wants to speak to you, and an X-ray to review. I'll give you guys a few seconds to have a think through how you would prioritise these jobs, what you think's more important and what might be able to wait for a bit. Because it's something that's quite important, especially when you're on call, trying to manage your time and to make sure that you're there for the patients that need you the most. So I'll talk you through how I would manage these. So the priority number 1 would be to see the patient who's unwell. They often will call you to say that the patient's scoring, so they've got a high, a news score is what we call it, where we're assessing their basic observations and using them as an indicator to say that something's not quite right. In any scenario, someone that's unwell is going to take priority over most of the other jobs, which can probably wait, but this patient should be your first priority to get reviewed. For some of the other jobs, I've not given that much information. So a patient that's in pain, making sure that they're comfortable, it's something that you would want to do sooner rather than later, but it depends on the scenario, and it depends on some of the other jobs as well. Reviewing an X-ray, once again, it depends on what the X-ray is for, to be honest, whether it's actually been done and what it's going to change. If you've got someone that's unwell and you want to see what's going on, then you might prioritise that a bit more. Speaking to families, it's a really important part of our job, and sometimes when you're on call and you've got a lot of other things to do, it can get forgotten about, but it's still something that you should try and make time for where you can. And then finally, discharge letters. There's something that they are important, and there's something that can get left often, but for someone that's going home the next day, the discharge letter can probably wait till a bit later on in the day, where you might have a bit more time and, you know, the unwell patient's been dealt with at the very least. So as with everything, medicine has its good points and its bad points. for me, the thing that I enjoy the most about my job, it's very rewarding. You get to be there for people and really make a difference to their life. And it's a privilege to be a part of some really life-changing moments for people. My first job was an obs and gynae, and getting to be there when parents were enjoying the first moments of their child's life was a real privilege. And you can meet some really wonderful people. I've met some amazing doctors during my time who are very caring, very intelligent people, and really make me enjoy my job even more and want to do even better. And it's great when you can actually fix things. So I want to do orthopedics. So fixing bones and getting to mend bones is something that it's really satisfying, both for you as the doctor, but also for the patients as well, to see the difference that it makes for them and to see how quickly you can help manage their pain. In terms of the things that aren't as great, medicine requires a lot of commitment. It's the kind of job where you don't always get as much of a break as you think about, as you like. You can work through your lunch breaks. You might end up staying late more often than you'd like, and even in terms of training, there are things that you have to do, and sometimes you have to go out of your way. So it can take quite a lot. It can be very busy at times. It's unpredictable what you'll be dealing with every day. Some days you'll have a lot going on, some days you won't have as much, and on the busier days it can get quite tough. But with a good team and good support, it's manageable. You do unfortunately get moments where you don't really feel appreciated. This can be by your colleagues or by the patients and their families, and those moments can be quite hard when you've done everything that you can and you've still not been able to get the results that you want, and people try to blame it on you. It can be quite tough at times like that. But I still wouldn't change my decision to do medicine. So now moving on to what the structure of training is like. So you've done your 5 or 6 years at medical school, and you start off as a foundation doctor. So your foundation years are 2 years. You tend to do a mixture of rotations. So you'll do some surgical jobs, some medical jobs. You might do a GP or special placement like pediatrics or obs and gynae. And they really serve as a foundation for the sort of skills that you need in a wide range of specialties. But then going on from that, the next step is your core training. So this is where you start to specialise a bit more. Depending on the pathway you choose, there's a number of different ones, things like whether you want to do medicine or surgery, psychiatry, GP, pediatrics or obs and gynae. You start to refine what your interests are a bit more. Following on from this, you have your specialty training. So this is when you're a registrar. By this point, you pick the speciality that you have an interest in, and you're focused on that. So with the exception of GP, where you, after the 3 years of training, you qualify. So this can be a longer journey, 4 to 6 years, depending on what specialty you choose. And at the end of the day, you get to become a consultant or a GP. Alongside this, the national training programme, there is also an academic programme. So during your medical school degree, you have the option to do a BSc, and this can be done in a wide range of things depending on what you're interested in. You might be a grad coming into medicine and already have a degree as well, or in that time during medical school, you might do a master's or a PhD. There is then an academic foundation programme that runs alongside the normal foundation programme, and you can specialise in a few different areas with this. So they have teaching academic programmes, they have research ones, and they also have leadership programmes. So you get allocated time to work on projects and work on other qualifications within those specific areas. As you go into specialty training, there's the option to do clinical fellowships and lectureships with the aim of getting an academic position as a senior lecturer as well. medicine isn't just the day job. There's a lot that you can do outside of it. So if research is something that you're interested in, as I already mentioned, there's the option to do an intercalated BSc during your degree. And you can choose to do this as something that you've got an interest in or something you want to learn more about. After you graduate, there's the options for fellowships as well within research. So once again, they can be done in a wide range of specialties depending on what you're interested in. And actually day to day as a doctor, we get involved in things like audits and quality improvement projects. So these you can do alongside your day job, but they involve looking at the practice that we've got at the moment and seeing how things can be improved. It's a very important part of the NHS and how things work, but it's something that a lot more people end up being involved in if research isn't your thing to quite that extent. As well as that, there's opportunities within teaching. So you can do clinical teaching fellowships, or you can, once you're further on in your training, you might become a tutor or a trainer or a supervisor. And actually day to day for most doctors, we have medical students that are on the wards and around. So you end up teaching them as you go around on ward rounds, or taking opportunities to do bedside teaching and getting involved from that point of view. So in summary, I think if you're doing medicine for the right reasons, you'll get there, you'll enjoy it. I certainly really enjoy my job day to day and have no regrets with my decision. And you can really make the career unique to you depending on what you're interested in, with things like research, with training, with the quality improvement projects that you can get involved with. And you can make a bigger impact than just on the level of an individual patient. And that's it. Thank you very much. We'll open up for questions.
Great, thank you very much. So we did have a few people join us over the last 10-15 minutes. So just for their benefit, the format of the session, Syra just spoke for about 20 minutes or so and presented the life of a doctor. It's quite important that we try and make this as interactive as possible for your benefit more than anything else. So we have had a question or two in the chat box. I'd really encourage you guys to ask more questions. There is no such thing as a silly question, and almost certainly everybody else is thinking of that same question. So ask away. We will try and answer them to our best of our abilities. You can either just unmute your mic, plus or minus take off your webcam and ask those questions, or you can put them in the chat box. So whilst we're waiting for some questions, so Syra, you've clearly presented a very balanced view of the life of a doctor, which was very interesting. In your opinion, in the last 2 years of being a doctor, what's been the best thing for you?
I don't know if I could pick one specific moment, but I think it's the patients where you've worked with them for a long time and you get to see an improvement. I think the one case that stuck with me was a lady that I worked with when I was on Jerry's, who came in and she had catatonic depression. She hadn't eaten for months, and she was with us because we were monitoring things for her while she was having treatment done with the psychiatry team. And we were getting to the point where we were thinking, oh, do we give up? We're not really getting anywhere with she was having ECT, so electric convulsive therapy, which is quite a lot. And that one day she just suddenly changed, and we managed to get her eating, we managed to get her mood up, and it was amazing to actually get to see a difference that you'd been able to make to someone's life. And it was a really amazing moment. So yeah.
Absolutely. I mean, I'm going to answer some of these questions myself after you, if that's okay with you. I mean, I think one thing that I've realized, I'm obviously a bit more senior to you and I've been doing this a bit longer, but one thing I've realized in my 10 years or so since I qualified is that actually people, when they come into hospital, are at their most vulnerable state. Okay, they are at their absolute most vulnerable state. And for family members, seeing their loved one in hospital at the mercy of the healthcare team is incredibly difficult. And you have this position of power, okay, which you can abuse, which unfortunately doctors have done in the past, or you can really relish it, you can cherish it, and you can really make a difference to people's lives. And I think for me, certainly, one of the things about medicine is that actually you make a huge difference to people's lives at a moment that they're most vulnerable. So like yourself, Sarah, I absolutely love my career. I wouldn't change it for the world. And now we've had quite a few questions come through, so I'm going to start going through some of these, otherwise I'll be talking all day. So a question from Arushi. What was it like in the first few days of being a junior doctor? Was it completely like jumping into the unknown? I might answer this as well after you, because my experience might be very different to yours, but yes.
So I was actually very fortunate in that the year I graduated, so my final few months of being a medical student, we had an assistantship program. So we spent, I spent 6 weeks shadowing an F2 doctor who was working on oncology. And for me, because I stayed in the area, it meant that by the end of the 6 weeks, I was very comfortable with the systems in Leicester, so the computer systems, how to make referrals to other specialties. And it meant that whilst my first couple of days were very daunting, especially for me in obs and gynae, I didn't have other SHOs. As an F1, we were still treated as an SHO, which is sort of like your F2s and your core training level. And the person that we referred to was our consultant. So it was a huge gap. But having known the systems, it felt a bit easier, but it was still very, very daunting. And almost a month before I truly felt comfortable as an F1, I would say.
So it's interesting because I thought you might say something like that. My experience as an F1 was very different. So I remember I started a hematology job, and at that time, so this is 2010, we didn't really have the shadowing period. We did a week, and I say this, I shouldn't really be saying this while we're recording, but I didn't really attend that. I went for the first day or two and thought, yeah, I'll be fine. And actually the first Friday, so Wednesday, Thursday was induction, and on Friday we were thrown onto the ward. And so we got to the ward at 4 o'clock, and then at 5 o'clock, everybody else said, oh, we're going home now, because I was on call that weekend. So there I was, Friday evening, 5 o'clock, on my own. Everybody, I was the most senior person on the hematology team, was a brand new doctor. And gosh, it was tough that weekend. But I grew up and I learned a huge amount. And I think that was the exception. Okay, so you will hear these stories. And I think a while ago, a few years ago, this happened more. Certainly my experience of now being a bit more senior and looking, helping the juniors, is that doesn't happen. So, there is a period where you will essentially be supernumerary almost, and you kind of just slowly, you embed into the team. So, that shouldn't be a concern. Of course, it's always going to be a leap and a jump, because you're going to go from being a student to being a professional. And that happens overnight. It really does. And the knowledge that you learn at medical school doesn't always help you practically. So it's a very steep learning curve, but there is plenty of support, and people will help you and guide you. Right. So the next question, is there anything you wish you knew before you started as a junior doctor?
I think the main thing is to never be scared to ask for help. Whether it be, for me on obs and gynae, midwives were an invaluable resource. And within a week or so, I've very quickly learned that actually they were almost like they were the people to go to first. And then if I wasn't sure, to then ask my consultant. But actually in any situation where I wasn't sure or wasn't happy, I was better off asking and having someone senior, even if they told me off afterwards. I would rather have that than do something I shouldn't have done or miss something and get blamed because I didn't escalate. So ask for help and don't worry about the consequences.
Yeah, I absolutely agree with that. So I've not got a huge amount to add for a change. Okay, right. So there's plenty of questions. Gosh. So did you have any doubts, Syra? And if so, how did you overcome them?
I think medical school can get quite tough, and the examination process at times more than anything, I had days where I felt I wasn't good enough to pass or to make it through. And actually, in those moments, I almost wanted it more. So I definitely had days where I didn't think I'd be good enough to get through, or didn't think I'd get there. But if anything, that pushed me more to work harder and to get there. And I think as long as you have the right motivations for it, why you're doing medicine, you'll get through.
Yeah, and I think I would echo those thoughts. I think really, and this is why we do Medsuccess, is really to equip you with that insight into whether medicine is the career for you. And for a lot of people who would be incredibly intelligent, they may turn around and say, medicine is not the right profession for me. And that's absolutely fine. I think I've seen a number of people, especially at medical school, drop out because they entered medicine because they thought it was the cool thing to do to make their parents happy, or that it would be prestigious, or that they'd get paid well. I think all of these reasons are quite weak reasons, if I'm entirely honest. And really, if you really want to do medicine, when it gets tough, and believe you me, it does get tough, okay? If any doctor says to you, I've got through my whole career never doubting this, I think they're probably either lying or they're deluded, one of the two. And I remember certainly when I was in my fourth year of medical school, I got to a phase where I just thought, I've had enough. I've had absolutely enough. I just want to qualify. I just want to finish. I just don't want to study anymore. And you have those moments. And what gets you through is the right attitude to the profession. And that's why it's really important that you do get that work experience, that you do talk to doctors, that you do engage with these types of programs to give you that insight. So moving on to the next question. When did you decide? So there's a question from Alina. When did you decide? And so, by the way, guys, the questions that we've answered so far, of course, you know they're your questions. If you want to have a follow-up question, you don't need to put it in the chat box. Just unmute your mic and just ask the question. We can have a conversation. It's absolutely fine. We're not scary. I might seem like it at times, but we're not scary. Okay, we can have a conversation. So, right, going back to Alina's question, when did you decide that you wanted to work towards a surgical career?
So this is actually quite interesting. So my dad is a urologist, so he's a surgeon. And when I started medical school, I was very much of the attitude that I would never do surgery. And I think a lot of it was down to the stereotypes, was that it's mostly men in the field, you have to be arrogant, you have to be almost the opposite of what I thought of myself to be. And when I started my surgical placement in fourth year of medical school, I really loved it. For me, I found that I liked the pace of it. I liked the fact that you saw results quickly. I realized that for me, medicine was the biggest thing in medicine was seeing a difference and having an impact, and that was the thing that motivated me. And I didn't get that satisfaction in medicine as opposed to surgery. So that's when I made the decision, and that's when I started to work towards a surgical career from that experience.
I mean, I'm a physician by background, so just to defend my colleagues. So this is really interesting, because actually my perspective is that actually I want to use my brain, and being a physician allows me to use that, whereas the surgeons, they're amazing with their hands and their dexterity. When it comes to using their brains, I'm sure they're super intelligent, there's no doubt, but more of it's about skill rather than using your brain. And so this is the beauty of medicine, that there are so many different pathways. And I remember, again, I just add my own little bit in, just to add another dimension into all these answers. I wanted to be a cardiologist when I was at school, when I was at university. And then I decided I wanted to be a GP. And then from GP, I decided I wanted to be an intensivist, and so an ITU doctor. And eventually I settled on respiratory medicine, and I absolutely love it. And so, one size doesn't fit all in this case. And you will go through your training, and things will change, every couple of years, and therefore to commit to something from now. And this is why when you get asked at your interview, so a lot of the answers that I'm giving you now is I'm also thinking of interviews. So I interview for medical schools as well. So I bring that perspective in. And so, it's okay to say that actually I have an interest in psychiatry, but I want to explore what my options are. That's better than saying I want to be a psychiatrist, because that's probably a little bit naive. And Syra hit the nail on the head. And when she said that she didn't actually want to be an orthopod, But as time has gone on, you know, surgery and orthopedics is what excites her, and that's absolutely fine. Okay, right, lots of questions. So next question. Ooh, that's a tough one. How do you deal with your work-life balance? Is there time to do other things outside of medicine? Well, clearly there is, because we're doing this, but well, that's where it is medicine, but it's not work-related medicine. But Syra, how do you deal with your work-life balance?
So to be honest, this was something that I struggled with a little bit at the beginning of med school. It was trying to find things that trying to make that time for work and for the rest of my life. I think it's about prioritization, but it's also about knowing when you need a break, when you've had enough. Actually, I realized very quickly that it's important to take care of yourself, whether that be spending time with family or friends, doing things that you enjoy, even physical activity. I found that actually when I was exercising and being active, I felt a lot better in myself. So I worked better, and I made it more of a priority. Whereas when I first started med school, everything, like nothing was more important than coming home and studying and getting those things done. So I think it's about making time, and it's about accepting that actually when you do the things that you enjoy outside of medicine, when you come back to it, it's easier and it's more enjoyable.
Yeah, I mean, you know, it can be tough, and I think, you know, like anything in life, it changes. So I go through periods where my work-life balance is amazing, and I think, gosh, I've got the balance right. I go through other periods, like the last 3 weeks, for example, where I've been just work, 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 work. And that's because I am doing research, and so I'm doing a PhD on the side, and one of my outputs is actually a paper related to COVID, and so I'm trying to get it out as quickly as possible. But that's the beauty of the career, that you will have these moments which will challenge you, and your work-life balance, unfortunately, will suffer. But it's all about bringing yourself back, realigning yourself, coming back to what your principles are, what your motivations are, what your goals for life are. And it does change, you know, throughout your career. So I don't think it's going to be a fixed recipe that will work throughout your 40 years of medicine. Right, so the next question. What are some of the clear differences between junior doctors and doctors who are completing core training?
So junior doctors is a very general term that I think encompasses actually pretty much everyone that isn't a consultant, if my understanding is right. So an F1 is a junior doctor, and a registrar is a junior doctor as well. So it's a very broad and general term. And essentially, most junior doctors will still be training, they'll still be learning and gaining knowledge and experience. As for specifically core training, it's one of the stages of the training programs I showed before. Yeah, I don't know if that answers your question. But the core training is part of being you are still a junior doctor when you are doing your core training.
Yeah, so just to add my little piece on that. So being an F1, F2 is very generic training, whereas when you're a core doctor, you're starting to specialize, okay? And you're starting to develop those skills in that particular specialty that you're interested in, whether that's being a physician, that's being a surgeon, a psychiatrist, a GP, you know, an anesthetist, whatever it may be. You are starting to develop those skills, and you are starting to complete your specialist exams as well. Well, as an F1, F2, it's just very broad-based generic training, 4 months, 6 rotations over 2 years, and you're just kind of getting a taste of things, okay? Whereas as a core doctor, core training doctor, responsibilities can be similar, but you're actually developing yourself more in that particular field that you're interested in. A question from Alia: can you still pursue other interests like arts outside work? So
You definitely can. I have friends who have done all sorts. So for me, I played the piano when I was at school, and it was something that was very important to me as stress relief. And I carried that on through most of my medical school. I still have a keyboard with me. I've cut down since I started working, but that's more because other things have come up in life that have taken priority, but not necessarily work. But I have a number of friends that are really passionate about painting. So I have a couple that do really marvelous like canvas pieces. So you definitely can, and I would encourage it, actually. I would encourage to have hobbies and other things going on outside of medicine.
Yeah, and I think the next question is related to that. Excuse me. As a student, junior doctor and qualified doctor, how much spare time do you have for hobbies, sports, spending time with family and friends? And I think Sarah's answered that with the previous question. But, you know, essentially, you have plenty of time. The only problem is your hours can be a little bit unsocial. So you do evenings, you do nights, you do weekends, and you don't do them all the time. Things have really drastically changed over the last 15, 20 years. They really have. But you do more unsocial hours than probably your colleagues in other professions, okay? And that's just something that you need to be aware of. So you will have the time, but you might not be able to commit to a Saturday evening class every Saturday, for example, because 1 in 6 Saturdays you'll be working, that kind of stuff, okay? What is it, oh, that's an interesting question from Katie. What is it like to perform surgery on a patient?
So to be honest, I've not done a lot of operating on my own. At this stage, most of it's about being an assistant and learning how to do things. I've done some very basic surgery, so I've drained a few abscesses, which is probably not very nice, but it was very exciting to have that opportunity, to be fair. The first time I got handed a scalpel, I felt very scared and didn't feel like I could be trusted with it. But with correct supervision, it's very satisfying. I really enjoy closing a wound, probably more than I do opening one. But getting to suture and to close things up, I find very satisfying. So yeah, it's good fun. It's exciting.
I can probably see why. My suturing skills are absolutely awful. I don't do much suturing. I only do suturing when I put in chest drains or central lines and things. But yeah, my suturing is not good. But this is why I'm a physician and not a surgeon. Right. Okay. So a question from Amna Afsan, and she sent it to me privately, but I presume it's for everybody. What was it like seeing your first patient?
Oh, my first patient. I'm trying to think back. I think I'm thinking back to my first day as an F1. I probably did see patients before that, but my first day I was on the maternity assessment unit, and I was so scared about like taking a history. It was a woman that had come in with she was maybe 26, 28 weeks through her pregnancy, and it came coming in with some pain, and she was quite uncomfortable, and it's very nerve-wracking because you want to ask the right questions, but you also want to seem like you know what you're doing. But with time, you get the confidence and it gets much easier. So yeah, I think the first couple of times it's nerve-wracking and you realise you miss half the things that you should ask, but you get there. And now I don't think I even think about it when I go to speak to a patient and take a history.
I remember when I saw my first patient, it was on that hematology shift, and it was a patient who was vomiting, and I had no clue what I needed to do. So I went to the nurses and said, I need to prescribe something. What should I prescribe? And they said, prescribe them cyclizine. I was like, okay, that sounds good. What's the dose? 50 milligrams. Great. All right, let's prescribe it. and I think one thing that somebody told me is actually, he's a consultant orthopedic surgeon. And I remember him telling me before I started, that keep the nurses in your good books, befriend the nurses, because your nurses have tons of experience, not all of them, but many of them will have tons of experience, and they will really help you out in your first few weeks and months as a doctor, and even beyond, you know, because it's all about teamwork. So they will help you, they will support you with jobs. And I think, you know, obviously you guys aren't at that phase now, but, you know, remember, it's all about working together in a team. And so you seeing your first patient may feel very daunting to you, but actually it's not just you, because you've got all that support with you. You've got the nurses, you've got other doctors, and they will support you through it. Right, a question from Mabel. Is all your learning hospital-based when you are a junior doctor, or do you still have some lectures, classroom-based learning like you would at medical school?
So as part of your foundation training, so for us as an F1, we had a weekly session. It was a Wednesday afternoons. Lunchtime teaching would be in a lecture theatre, and we'd go through various different topics. A few times we even had the clinical director come and speak to us to understand concerns. So you still do have sessions like that. Most departments will also run teaching for their juniors, where they'll do lectures as well and talk about topics relevant to the specialty that you're in, so you're understanding more about the patients that you're seeing. So you do still get it, but actually you learn a lot on the job, from the basics of the jobs that you have to do as an F1 to also the details that are more decisions at the consultant level, but understanding the science and the research and the evidence behind why you're doing the things you're doing to your patients.
Yeah. Okay, and let's move on to the next question. So again, as I said, guys, just to reiterate, if you have a follow-up question and you want to ask something, so Cyrus says something, just unmute your microphones. Don't be shy. Ask the question. Right, guys. So, Cyrus, next question. How do you find working with the multidisciplinary team?
I think, like you said before, working with the team makes you feel like you're not on your own. And actually, if you utilize the different members of your team, you are really able to give patients a holistic approach to managing them. I think the perfect example of this is with your elderly patients who have, it's not just the medical problems that they come in with, it's managing them, preparing them to go home. So the occupational therapists and the physiotherapists are very important. The nurses know a lot more about the patients because they spend a lot more time with them, and the healthcare assistants as well. And they are able to contribute to their care and to help you understand what's going on and how to manage things, but they're also able to help you do things. So I really enjoy it. It's one of my favorite parts of the job, working with the team, and you really can gain a lot from it if you work together well.
And I think it's really important that you guys realize this. So I don't know what stages you guys are at, but for those of you that have applied and have got medical interviews coming up, I think it's really important that you can demonstrate you understand and recognize the importance of the MDT. You know, what we don't want to see in the interview are cocky, arrogant, 17, 18-year-olds who think that once they become doctors, they'll have all the power, with their stethoscope and pen. And I'm sure none of you will come across like that, but I definitely interview people and they do give me that impression. And what we want to see is, we want to see people who have some realization of their limitations and realize that actually medicine is all about working in a team, however junior or senior you are, whatever specialty you are. And that MDT works together with one objective, and that objective is the patient. Okay, and it's really important to realize that the doctor leads the MDT. Medicine remains very hierarchical, despite what we say. The doctor leads that MDT, but the MDT have a critical input. So the occupational therapist, the physiotherapist, the pharmacists, and the list goes on, the nurses and so forth. Okay, so another question from Marushi. Are there times when you don't know how to manage a situation or don't know the knowledge? How do you stop feeling frustrated during those times?
So one of the things that you learn at medical school is almost frameworks for how to deal with certain things. So for an example, a normal patient, you have an A to E approach to assess them and to try and identify the things that are going to kill them first. And in times where I feel like I'm missing something or I feel overwhelmed, I try and go back to my basics to make sure I've covered everything and I've gone through all the things that could be going wrong in my head. And then it's your team, it's your nursing staff, it's your seniors, it's having a discussion with them. And I think it's accepting that you're not always going to know the answer, you're not always going to be able to fix everything. And sometimes it's prioritizing what matters most in that moment. So yeah, it can get frustrating, but I think with the right attitude and the right approach, anything seems a lot easier.
Absolutely. Indeed. Right. Okay. So we're just entering into the last 10 minutes. We've got a couple more questions. So we'll go through these questions. So guys, this is your last chance. If you have any of the questions, get them in the chat box now. Otherwise, we are going to run out of time. In fact, we may already have run out of time. So, question from Amna Afzal. We've answered this already. What's your favorite thing about being a doctor, and what's your least favorite thing? I think I asked this question at the beginning, so we're going to skip. Do you want to just answer that question, because Amna might have missed the answer? Do you just want to answer it again? So what's your favorite thing about being a doctor, and what's your least favorite thing?
So my favorite thing is getting to make a difference to people's lives and getting to see the results of your hard work. My least favorite thing is realizing that despite all your efforts, sometimes you can't make the change that you want, and realizing that actually there are some things beyond your control, even with the resources and technology that we have available.
Okay, and Helen's questions of what responsibilities do you have as a junior doctor? Gosh, that's your whole presentation again. Go on, summarize in a couple of sentences for Helen's benefit.
So as a junior doctor, a fair amount of it can feel like admin work at times, but it's on a basic level, having an idea of what's going on with the patients, requesting scans, speaking to other departments, doing discharge letters, taking bloods. The bigger decision making ends up being with the consultants, but if someone does become acutely unwell, you end up having the responsibility of assessing them and starting to do a few basic things and then escalating it to your seniors.
Yeah, okay. And I think, you know, the presentation will be available later. So I know Sarah's gone through this in a bit more detail. So if you missed that, Helen, then you certainly can view that online and through our website and Facebook page. So it should be up in the next few weeks. What responsibility? No, sorry, we've done that one. What are the main differences? From a question from Katie. What are the main differences between doctors, nurses, and midwives?
So, as doctors, you are more involved with clinical decision making. So it's using all the information you have to make a diagnosis and to make a management plan specific to a patient's illness. Nurses are a lot more involved with patient care. So they're the ones that will be going around administering medications, reviewing their patients' observations. They end up spending a lot more time with patients than we do as doctors. So they are a very valuable source of information. Midwives only really exist in obs and gynae, and have a similar role to nurses in that they spend a lot more time with patients and manage a lot more. They will manage deliveries for very basic, uncomplicated pregnancies. And yeah, they're much more specialist than I certainly was as an F1 in terms of their knowledge around pregnancy and giving birth. But once again, you still have senior doctors that end up making more specialist decisions in more complicated scenarios.
Thank you. So the next question is probably, I mean, it's a great question, but I think it may not be appropriate for the webinar. I suppose the bits that I can take out of this question. So just to read the question out, and then I'll rephrase it into the bits I want you to answer. So I'm writing a dissertation on immune regulation stem cell transplantation. Sounds fascinating. Have you been around these transplants, and what is the standard procedure medication normally given? Also, what is the biggest impact you have witnessed? So I'm not going to ask you to talk about the procedure and the medication given, because that's A, might be beyond your remit, but B, also is probably not, you know, within the scope of the webinar. But perhaps you could talk about the biggest impact of some surgery that you've seen. If you have seen any transplant surgery in particular, that'd be great. But if not, then any other surgery, the biggest impact that you've witnessed?
So I've not really been exposed to transplants, to be honest. In terms of generally impacts that I've seen, so at the moment I'm working in the major trauma centre, and we see some really complicated patients that have come in with multiple injuries, and they've been through, they've come from road traffic accidents, or really, and they've sustained really significant injuries, and it's really amazing to see the recovery that these patients have. So we had a young girl that came in when I first started, who'd come in a road traffic accident, had some really significant injuries to her legs, and had a bleed on her brain. And we were really worried about how she would recover. And we've recently discharged her to a rehab hospital. We got to see her talking and communicating, which for a long time we were worried we wouldn't. So I think the current job that I'm in has really made me realize the powers of medicine and how big an impact you can have when you're dealing with patients who have suffered trauma and you manage to get them to a much better place and save them.
Yeah. Okay, so we have a couple of minutes left. There are no other questions in the chat box. I think we've answered, we've done really well to get through all of them. There've been lots and lots of questions. So very succinct answers. If it was me, we'd probably still be on the second question right now. But in the last minute or two, do we have any other final questions from anybody? This is your opportunity, this is your chance. You've probably realized that we're not picking on anybody, we're not intimidating anybody, we're not patronizing anybody, we're just trying to help you guys. So if you have any other questions, anything that you want answering, anything that you're not sure about, or something that even you do know the answer, but actually just want another opinion on, put it in the chat box. We've probably got time for one more question if it comes to the next 20 seconds or so. If not, then of course we will look to wrap up the session. So whilst, okay, somebody's come in. Oh, that old age question. Okay, we will answer that one quickly, and this will be the last question. So, what made you want to be a doctor? And then I've got one last question for you, Sarah.
I think for me, my dad was probably a huge influence in why I chose to do medicine. He was always very passionate about his job. He loved, in the same way as me, he loved being able to make a difference to people's lives and to have that impact. And I think growing up, seeing the respect that he got and seeing how much he enjoyed his job was what made me consider a career in medicine. And then as I've gone on to do work experience and get into medical school, I think those ideals of being able to really have an impact on someone's life and to even physically be able to change things for them is why I enjoy what I do.
I think, this question, what made you want to be a doctor? I think it's a really tough question. It's a really difficult question. And what I would encourage everybody to do is to really dig deep and reflect. What is it that attracts them to the profession? And really articulate that. Because if you can explain that to yourself in the mirror, that will have two effects. One, it'll help to reaffirm those thoughts in your head. And secondly, when it comes to the interview, you will come across a lot better. If you try and learn somebody else's answer, it will be very apparent, And so it's probably the hardest question there is, even though you'd think it's probably the easiest question. You ask me why I want to be a doctor, this is what I've applied for. It's like, for example, if you go to watch a cricket match, why have you gone to watch a cricket match? That's the easy question to answer. But why this question is so difficult to answer. So I would encourage you all to really reflect on that. And now we have hit 8 o'clock. Sarah, what one piece of advice would you give our audience about, I'm presuming maybe everybody or all of them are considering careers in medicine. If you could go back, to this stage when you were 17, 18 and applying to medical school, 16, what one piece of advice would you want to hear?
If you're doing it for the right reasons, whatever happens, don't give up. And it will be worth it.
I love it. I think I would definitely agree with that. Okay, if you'd asked me for one piece of advice, that's probably something I would have said something very similar. Right, guys. So we have sadly come to the end of the session. I would like to thank Sarah for giving up her time, for preparing the presentation and delivering here today. So I hope it has been helpful, and there's a lot of thank you messages coming through in the chat box, so thank you guys, really appreciate your kind words. Thank you to you all for tuning in. We are doing the webinar series, and the next week's session is about wider reading of the medical literature. And the reason we've chosen that topic is this is something that often comes up in interviews, and also people are not really sure how to go about their preparation in terms of understanding medical topics. So hopefully that will be really interesting. Dr. Emily Ratford is running that session next week, and I'm sure she will have plenty of good things to say and plenty of insight to give you guys. I do hope the sessions have been helpful up until now. So we've had 3 sessions. It'd be great if you could spread the word to your colleagues and peers and friends and family who are also considering careers in medicine, or even dentistry, as there's a lot of similarity and overlap. The more of you that we can have, the more it encourages us more than anything. I mean, you know, it's great to have 18 people, and that's amazing. But if we have 100, it's even more motivating. Okay, so it'd be great if you could, you know, pass the message on to your peers, as mentioned. But yeah, I'd like to thank Sarah once again, and thank you all. And I wish you guys the best of luck. And I look forward to seeing you again next week and in subsequent weeks. Take care. Bye bye.
Hi. Good luck, everyone.